you can teach people how to do things. You can train them. Ultimately, they might forget under stress. But if you design things so that they can only do the right thing, so it can be as easy as possible for them, then you're more likely to get the outcome that you're looking for. And you're shifting the probabilities towards success.
This is great. So, do you mind giving a brief introduction about yourself?
Yeah, thanks for having me on, and I appreciate being here. I'm an emerge doc and a trauma doc at St. Mike's in Toronto, and I'm also our medical director at Unity Health for our simulation program. And I have an interest in simulation, in design, and the intersection with performance and people and the built environment. And for the last several years, also been doing some work with. We created Advanced Performance, which is a firm that does consulting work for across a few different industries around performance with teams, as well as simulation programs and building out clinical environments and working with architects and clinicians on the designs of those things. So.
Incredible. And then I'll butter you up for a second because I know you won't say this because you're incredibly humble, but you're world renowned and nationally known and international speaker on all those topics. And you're one of our most sought off guests as well. And just thinking about this from a different lens. So we really appreciate you taking this time and get to learn and pick from your brain.
Well, yeah, thanks very much. Super kind words. I guess we'll see if listenership goes up or down after this.
Oh, it'll go up. So tell me, how did you get into all this? Like, what sparked your passion in doing this optimizing performance for teams?
Um, I think it started in residency. I was always interested in education. I think one of the things I like about education is its ability to um, you can scale your impact, and you can certainly have impact at the bedside. And I think that's what many of us feel like we do on a regular basis. But a better way to scale that is by educating others. um I'm fond of the quote by Nelson Mandela: education is the most powerful weapon which you can use to change the world. And I think that has always been something that it has interested me, and I got into simulation because I thought, what better way to do education than to actually practice and trial and train doing the actual thing rather than just thinking about the thing. And so that kind of emerged through my residency program in Toronto as an emergency physician. And then I had the opportunity to go to New Zealand in residency near the end. A mentor of mine, Dr. Chris Denny, Canadian, actually moved to New Zealand, and he's the medical director and sort of overseeing uh, the Auckland HEMS program. And they were just starting up some new programs within that, and he thought it would be an opportunity to come down as a simulation fellow. And so I went down there, and Chris is a super innovative guy. He really pushed me to sort of think outside the box, and working in on the helicopter, on a daily basis. So I worked clinically with the paramedics. Our team was, to give some context, it was a pilot, crewman, paramedic, and MD, and that was a relatively new model. And I'd never, I didn't have any experience in the pre-hospital space, and I didn't have any experience in flying helicopters for sure. And so that was really great. And a lot of that, that really kind of brings forward, like, it pushes you to the limits of you suddenly have all of these confines. You have safety becomes the most paramount. your own safety as you're looking to help others, something that I really hadn't thought about. And then you start to see other industries intersect with your own, meaning aviation. We were working alongside these crewmen who were sort of like tacticians and logisticians who weren't clinical, but their jobs were to figure out hard problems, in terms of where we're going to land, or we would land in like in a field and we couldn't get out, and then suddenly like there was a fence that had just been moved by the crewman, like as he just like runs back to the helicopter, and you're like, oh, now I can get the stretcher to where it needs to go, and just stuff. They just made stuff happen, and I think part of that is maybe N- New Zealanders in general. They just like get things done, and make things happen, and nothing's really a problem. But even within the Auckland Hems program, I really got to learn from people outside of medicine, and obviously I got to learn from the paramedics who I would work alongside, who taught me pretty much everything I know about pre-hospital care, and what I needed to think about, and the considerations, and how we're going to run a cardiac arrest on the beach, or how we're going to winch down to this patient, and all of these things that I had not learned in my residency program. And so that as I was down there, I was tasked with working on training and as a simulation fellow. And it also then became quite clear that you can teach people how to do things. You can train them. Ultimately, they might forget under stress. But if you design things so that they can only do the right thing, so it can be as easy as possible for them, then you're more likely to get the outcome that you're looking for. And you're shifting the probabilities towards success. And there was really no way of we couldn't go to a sim lab. There was no helicopter sim lab. We would just work in the back of the helicopter. So we were doing in situ simulation, which at the time was relatively novel. Now, people do it everywhere all the time. And but for us, it was quite different. And we would interrogate how the packs were set up, and we would trial all of these different ways of packing and laying out equipment. And we were, when we were doing RSIs in the pre-hospital space, we had to get it right, because this was a relatively new program, so failure wasn't really an option. And so if we could design things to favor success rather than just hoping, which is not a great strategy, that things would go okay, we were able to achieve the outcomes that we wanted. And so it was that experience being in New Zealand, being under um, the mentorship of Chris Denny and the teams down there. And I think, learning from pilots, like hearing them talk, hearing how they think. So we would have briefings with them, and they just had to, I thought we were safety focused. I mean, that is a safety focused domain, beyond anything I've ever seen. And so just just the communication styles, the directness, the no nonsense, no BS, direct to the point. No one takes anything personally. It's just, here's a matter of fact. Here's how, we have a problem. How are we going to solve it? And so I think this was really sort of what got me interested in human factors, performance, and the intersection with the built environment.
So what I hear you saying is that that was such an enriching experience, and I'm sure you're like, "This is part of my training. I'm gonna get clinical acumen even more," but I didn't realize I was going to get this whole different perspective of different industries and how we need to optimize healthcare, everything we can learn from aviation industry. Because when we were speaking offline, the aviation industry, like you said, is the safest, most well thought out, objective kind of industry there is. And you've had human factors experts come in and look at the emerge and they say, you guys are great, but you make your lives very hard by tripping over wires. Like, why is the monitor screen over there and you have to turn and look when you're intubating? So, what else did you learn from them that we can take away and make sure patients are safe?
Yeah, I mean, I would even take a step back. The first thing that I learned, I think there are other ways of doing things that non healthcare providers have figured out. And so even before just talking about aviation, just the fact that I was exposed to other domains, other high performance industries, I think is something that I now continue to use and look to. In fact, I spend probably 20-30% of my time thinking and looking towards other industries outside of healthcare to learn how people are working there. How are they thinking about problems? Because I think that to me is, has become really interesting. How do psychologists think about a particular problem? How do human factors experts think about a particular problem? How do how do athletes solve certain performance problems? And so that was my first introduction. All I had known for probably 10 years at that time was doctors, nurses, RTs, paramedics teaching me how to be a better doctor. Okay, that's great, and I'm certainly grateful for all their teaching. What they weren't able to offer me is how do people in business think about risk? How do when money's on the line? And I think it's interesting because obviously we're talking about human lives, but you you, the same stress is elicited when you're talking about a $1 billion deal. I have to imagine. I've never done a $1 billion deal, but I have to imagine that that same stress response would come if you're taking care of a patient or some other high stakes decision. And so I think the first thing I learned was the importance and really the experience we can gain from outside of healthcare came apparent. Um, I also learned very acutely how important the environment is around us in terms of shaping our behavior. And there's a quote from James Clear, who's the author of Atomic Habits, which I'm sure is a sort of a bestseller, and many people have probably read. The environment is the invisible hand that shapes human behavior, and it basically gets at this idea that if you want to change behavior, if you want to impact behavior, ultimately that behavior leads to performance, then we can have a pretty big impact, maybe an outsized impact, by changing or affecting or studying the environment around us. Oftentimes, when we focus on education, and that's how I kind of grew up. I I did a master's in medical education. I it was very much like, let's, if we can just figure out better ways to teach people, then we can solve a lot of problems, which I'm a little less bullish on now, because under stress and under certain conditions, that education sometimes, you forget things. But if I can make it so that when I open up a pack in a pre-hospital setting and the thing I need is right there, I grab the laryngoscope because it's right there and I'm not searching for, something, um, then I can really impact the the clinical tasks that in a positive way or a negative way, obviously, if I design it wrong. And the other thing that I think I learned was the power of iteration. And I've since kind of dug into this with my interest in design. That I'm a really big fan of pilot testing things, A/B testing things, of trialing things, prototyping things, so that we get feedback from the end users. And I'm really not a big fan of what often happens in healthcare, doesn't matter where, is this idea of an idea goes from idea to implementation without any testing. And so I try not to use that word implementation, because not because it's a bad word, but because it sort of, um, I think, has a connotation around permanence and finality that I really don't love. Because unless it's a one-way door decision, the way that Bezos talks about one-way door and two-way doors, like unless you a two-way door, meaning you can walk it back, right? If you make the decision, you can decide later on, okay, that wasn't the right decision. A one-way door would be like, paralyzing a patient in an RSI, you really you're all in, okay, and that's fair. There are one-way decisions, but most are two-way door decisions, and so, a policy in place is often a two-way door decision, like, you can put it in, trial it, see get some feedback, 3-month trial. Is it working? Is it doing the thing it's supposed to do or not? And so, I think I learned that, we can especially in the work environment, we should see things as just as iterative with really building out mechanisms and systems so that we can have feedback from those using it. Because to borrow from Rumsfeld, like there are so many unknown unknowns. We design a protocol for a clinical task. We just can't know all of the things that might impact that. It's all well intentioned. It occurs around a boardroom, but we just simply can't understand all of the complexities that might occur.
Correct me if I'm wrong with this, that what I hear you saying is obviously everything's iterative. We shouldn't think a finality of anything. And that kind of stems from, I'll grab something from outside healthcare. It's Toyota. Everyone in the world copies Toyota production system because they're always iterating. It's continuous improvement. We always have and will improve. And people laugh when they hear Toyota, but they're like the industry standard for quality and effectiveness. And also what I'm hearing you saying is control the controllables. Like there's so much things we can't control, but to optimize performance, let's control everything we can and have a human centered kind of lens to it to design it with the end user involved.
Yeah, that's it. It's better. You said it better than I did.
No, I was just listening intently to all your wisdom.
When people hear, you reference and you reference Toyota, which is like a good example. Some people get a little apprehensive, like, well, yeah, but healthcare is different than an assembly line and stuff. And I think that's important to acknowledge, like calling those things out. The comparisons are never perfect. We're not aviation. Simulation came from the aviation industry, kind of borrowed in and brought in by predominantly like anesthesia back in the 80s, 90s as they were training within the OR. That same model came, but we're not. I can't say that we are the same as an aviation industry. Like there are a lot of differences. It doesn't mean that you can't borrow some key principles or some key ideas. Or the same with Toyota. We're not an assembly line. We don't treat patients the same way that you would imagine you're assembling a car. But there are ideas there that are probably strong that can be borrowed, can be shaped to be used within healthcare, to be used within acute care medicine. And then some won't be applicable. And I think that's often what when people you look outside to other domains, people are like, well, I can't use that because doesn't that's not specifically applicable to everything about my view of healthcare. And that's not the point. The point is to look to other industries like athletics or like aviation or like the car industry in terms of them optimizing for building at scale, and then take pieces of that and trial things and look to other people. There's so many smart people out there. It would be ignorant of us to imagine that we can only get our own ideas from within healthcare, which I think will long term would be entirely problematic.
And if we look at stuff we can grab from athletics, like we'll say the obvious, let's say LeBron James controls everything he can to overall achieve the highest performance that he can, but also they work as a team together. And there's a lot of moving parts, especially for a trauma call. Like if I come in from the pre-hospital setting to St. Mike's with a trauma call, very different specialties, very different perspectives amongst everyone. And it's like we haven't had the ability to have that interprofessional training and talking. So that is a huge and understood gap in the healthcare world. How can we improve that though?
Yeah, I mean it's a great question. I mean, one of the challenges that LeBron James doesn't face, or any kind of team that athletics team, is that they have a fairly structured team that's there every day, right? In contrast to us, often. I mean, sometimes like a paramedic team might have the same small group. When I worked in New Zealand, there were only a few paramedics within our group, so you could kind of actually train together. But if you talk about something more broad, like Toronto EMS, Durham EMS, like you're going to be on with different people all the time. You're interacting with different people. It's very ad hoc, just like we are in the trauma bay. And so there are differences that we can't borrow exclusively from athletics. I think what all teams do, all good teams do very well, is in some way they establish a shared mental model of what their goal is, and how that's done is done. Depends on the domain in which you're speaking about, but this idea of getting everybody on the same page quite quickly. An athletic team, um, I'm sure, JJ Redick at the beginning of the year sat everybody down on the LA Lakers, including LeBron, and said, "Here's our goal." I mean, probably it's to win a championship. But there's probably more nuanced goals than that, and they got everybody on the same page, and he probably had several weeks to do that in training camp. In contrast to us, when we're working, let's say a trauma patient or a critic, show up at a scene call and it's cardiac arrest. The there may be different priorities, and there may be different options. You're going to have to figure out, is this all just trauma? Like, how are we going to resuscitate this patient? Might be an extrication problem. They might be in a basement of a house. There's going to be different things each time, and so that you will quickly need to get um, onto the same page. And so I think that probably underpins, you know, much of a team's ability to perform is the ability to quickly establish, at least particularly for ad hoc teams, a shared mental model. Hey, we are all going to work towards the same thing. The ability to establish that quickly will then, you know, impact how I think the team's performance will be. If you really have to say everything back and forth, if you and I are on a scene call together and like I'm totally on one wavelength and you're on another, and we have to have lots of back and forth conversation because I'm trying to argue my point as to why we should be focusing on scene safety and you're thinking about getting this patient, IV access and rapidly to hospital and, whatever, then that's going to be challenging because now we're arguing in the middle of of something that argue is time sensitive. But if we are both on the same page, the implicit coordination, the idea that things happen without us even, I just look at you, you look at me, you nod, and we both know whatever that means. That means like, let's go and whatever, we're going to, start with extrication first, or we got to figure out a scene safety plan here or something like that. That will allow the team, our team to perform better. And so, there are ways in which people have kind of described to do this. The 0 point survey is a framework that has been described, that's kind of like before you, um, get to the patient, and it's this idea, it uses a mnemonic. It's been published and described and I think is a good framework. I mean, I don't know that I remember it all the time, but I kinda use it generally. It's this idea of, like, getting yourself ready, so the mnemonic is step up. And I don't think I would remember that in real time, but the idea, it's like, okay, figure yourself out first. Like, if you really need to pee and you're gonna be, like, doing a you have a cardiac arrest in front of you, like, that's gonna be a problem because you're not gonna be focused. Get yourself ready, there might be some stuff you can't change, like you had a terrible sleep last night, but it's self and then team and, deciding, okay, quickly who's doing what, team allocation or role allocation, a leader, and then the environment, are we optimized? Is there danger? Is there, is light or noise going to be an issue? Is there crowd control problems? And then, do we have all of our equipment? And and then now we sort of initiate the resuscitation and we do our primary survey the way that, we all are taught. And then so we're at step. So that's self, team, environment, then the patient as we begin our resuscitation, and then you update. Okay, um, you have limited information when you arrive. Now you have more information because you've spent 5 minutes there, 10 minutes there. So you update, and then you kind of share priorities, and so it's step up. So you have self, team, environment, patient, update your mental model, and then reset some priorities. And through that's dynamic. It doesn't, it might happen. It's not linear. But these are ways in which using that framework, or something similar to it, you can reliably and readily fall back to a bit of a plan. I think, again, James Clear says you don't rise to the level of your goals, you fall to levels of your systems. Might have gotten that wrong a little bit, but if you have a good system that you can fall back on, then you're more likely to have a predictable and reliable outcome. Doesn't mean everything will always go right all the time, but you're backstopped by a system that should help to support the challenge that's in front of you.
I love that you said one of the first steps is to take care of yourself. Like, if I have to pee, I have to pee. I'm going to be distracted. I don't know if you read his book, Dr. Brian Goldman's teamwork book. So it talks about teamwork, and especially in healthcare, they had a Navy SEAL come in and view everything. And they're like, you guys are great, but you can definitely improve your teamwork, because he's like, the Navy SEALs beat you down. After they know you can get beaten down, they rise you up to control everything. Like, how's your flu? P, we work together. But in kind of healthcare, we just kind of keep you beaten down. So it's that culture that we try to work through suboptimal environments. So I'm glad you have that perspective.